All right, well, the clock over in my office at least is showing noon, so we're going to go ahead and get started. I'm sure we'll have some people coming in over the next few minutes, and that is just fine. But I want to make sure that we give today's presenter as much time as possible. But thank you for being here. Welcome. My name is Kayla, and I am with the Metro Council, which is a collaborative organization representing the public mental health system here in Kansas City. So we are all of the community mental health centers from across the greater Kansas City metropolitan area. We provide support to our member organizations as well as education, information, and resources to the public on accessing quality mental health services. We also host the Mental Health KC conference every May, which we hope that you have either been to or plan to attend in the future. And we also host these free webinars on the second and fourth Thursday of every month. You've been seeing this slide that reminds you that as a disclaimer, the views and opinions presented are those of the speaker and don't necessarily represent the opinions of Metro Council. And as a reminder, at the end of the webinar today, we will put the link and password to get your certificate of attendance for the webinar. So please be sure to stick around for the duration of the webinar, because I promise you're not going to want to miss it. It is my honor to introduce Sonya Alexander, speaking on the topic of suicide. It's everyone's business. Sonya is a colleague of mine here at Wyandotte Behavioral Health Network. She is a licensed clinical social worker with extensive practice experience across various professional sectors, including arts and education, child welfare, medical social work, and higher education. She currently serves as the manager of community-based clinical programs at PACES, which is one of the 4 agencies within the Wyandotte Behavioral Health Network, which is the CCBHC serving Wyandotte County. In her role, Sonya collaborates with a team of trained community-based therapists to deliver individual and family therapy in participating schools within USD 500 and USD 204. In addition to her position at PACES, Sonya is an adjunct instructor at the University of Kansas School of Social Welfare, where she has taught social work practice courses for both BSW and MSW students. Her course offerings include topics such as dismantling white supremacy, diversity, equity, and inclusion in social work practice, and trauma-related care across the life course. Sonya is dedicated to suicide prevention, which is both a personal and professional passion, and holds certification in Question, Persuade, Refer, QPR, which is an evidence-based framework developed by Dr. Paul Quinnett to effectively engage in discussions about suicide. Sonya is also a Doctor of Social Work student at the University of Kansas. She's a very busy woman, and we are thankful to have her here today. So Sonya, I will go ahead and stop my screen share and let you get started.
Hello, everyone, and thank you. Thank you so much for the generous and gracious introduction, Kayla. I am really, really honored to be here to have a conversation about suicide. So I'm going to share my screen. Um, so today's topic is in honor of Suicide Awareness Month. And this conversation is personal for me as well as professional. I am committed because I have experienced personally 2 family members who have died by suicide in my lifetime. And it has compelled me to be a part of the conversation, to be a contributor. It has also compelled me to commit my practice as a clinical social worker to helping individuals who disclose that they find themselves on the continuum. So I am just going to have a conversation with you today. And some of this information may be a reminder. I think repetition is key to learning. So please, hopefully you will walk away with something that, oh yes, I was reminded of that, or I didn't know that. Okay, so moving forward. So by the end of this webinar, I hope to help you recognize the importance of suicide prevention. I also hope to help you acknowledge that suicide can be a form of communication and how we can intervene effectively to disrupt the continuum of suicide by implementing best practices, and we'll talk about what those are. And then we'll familiarize ourselves with what's available in the community to help you be a contributor and to have consistent conversations about suicide. So hopefully within the next 50 minutes, you will walk away with one thing that will help aid you in being a contributor in the conversation of suicide. So let's talk about what suicide is. This is where you might need, this is maybe a reminder. So suicide is defined as death caused by a self-directed injurious behavior with the intent, that is the key word, intent to die as a result of the behavior. Second to that is a suicide attempt, which is seen as something non-fatal, behavior that's non-fatal, self-directed, potentially injurious behavior with the intent to die as a result of the behavior. And a suicide attempt may not result in injury. So that is something that we want to keep in mind as we are contributing to the conversation of suicide. And of course, lastly, suicide ideation refers to thinking about, considering, or planning suicide. So for me, as a social worker, I like to metaphorically see these terms on a continuum, starting with suicide ideation, going to suicide attempt, or possibly a completed suicide. We never know where someone may be on that continuum, and this is why having this conversation is so important. So why? Why are we here? Why do we need to have this conversation? Why is it so important for us to know what the purpose is of this conversation? So I have an infographic here, and I retrieved this data from the Center of Disease Control and Prevention. And I want to draw your attention to some colors here. And there's a column 10 to 14. It says here that it is the second leading cause of death amongst 10 to 14-year-old. And then in the next column is 15 to 24, which is the third leading cause. And to me, that says, oh my goodness, young people aren't living full lives. They're not reaching the ability to be self-actualized. And so therefore, that's why we need to have this conversation, because then it begs to consider, well, what's happening to these 10 to 24-year-old individuals that may be contributing to this experience. So also from the Centers of Disease Control and Prevention is high school students. So at PACES, I work with therapists who work directly with children, youth, and adolescents within the school district. And so from a prevention perspective, I want us to look at these numbers. And these are the high school students who have felt persistently sad or hopeless across our nation. And it has broken down here between gender, ethnicity, sexual identity, and sex acts contacts. And just look at the startling numbers. Females are more vulnerable than males. Multiracial and Hispanic people of color are close behind. And then our LGBTQ plus community is 69%. 69%. And so again, if the data says that from 10 to 24, that is the second and third leading cause of death, it makes me wonder, is there any correlation between the data that I have here before you? So this is adding to my why, right? And my purpose of having this conversation, because it says to me that our young people are persistently feeling sad and hopeless, persistently. So now I feel like we need to drill down deeper as to what may be contributing to these persistent feelings of sadness and hopelessness. And of course, this is data about attempted suicide. So now we have feelings persistently of sadness and hopelessness to an attempt. And so look at these numbers: females, 13%. And then our indigenous population, American Indian and Alaska Native, 16%. And multiracial people of color, these communities of individuals are really fragile, persistently hopeless, or in feeling sad. Again, I'm questioning this data to understand what is happening. And of course, our LGBTQ plus individuals also are struggling at 22%. So this contributes to the whole idea of why we're needing to have this conversation, why suicide awareness should not just only be in September, it should also be throughout the entire year. So if suicide can be seen as a type of behavior, then there may be clues and warning signs. So very fundamentally, the more clues and signs you see, the bigger the risk. So we need to take all signs seriously. So thinking about that continuum I talked about earlier, is that we never really know where a young person may be on that continuum. We don't know if they are thinking about suicide. We don't know if they've made an attempt or having a plan in place. And we don't know where they may fall or may not fall. So therefore, we need to take all signs seriously. So how do we do that? We pay attention. This requires us to do some things. It doesn't just miraculously happen that we know. We have to actually pay attention to how young people are communicating both behaviorally and communicatively. So it could be that a person may say to you, I've decided to kill myself, or I wish I were dead, or I'm going to end it all. And if such and such does not happen, I will kill myself. Those are very direct statements that will probably get your attention. But then on the other end of that is the nonverbal, the indirect verbal clues, things that may be very subtle. My family will be better off without me. Who cares if I'm dead anyway? I won't be around much longer. Pretty soon you won't have to worry about me. In my practice as a social worker and a therapist, I've heard these statements. Some were direct and some were indirect. But it's my response to these statements that is very, very vital. So behavioral. So suicide is a type of behavior, and how is it communicated, right? That is the question. And so this is why we assess for previous suicide attempts. This is why we ask questions about what are you doing? This is your intent here. Acquiring a gun or stockpiling pills, giving away prized possessions, impulsivity, increased risk-taking. And I would add, depending upon what community you serve within, I would probably add delinquent behavior, co-occurring depression, moodiness, and hopelessness, unexplained anger, aggression, irritability, self-destructive acts, i.e. self-harm, and then of course, chronic truancy, elopement, or running away. So a couple of things I would like to bring to your attention. Co-occurring depression. It is the manifestation of moodiness and hopelessness. It is not depression in and of itself, because I know a lot of youth who live successfully with the experience of depression. It is the manifestation, is that social isolation, the fatigue, the lack of motivation. It is all of those things that can contribute to possibly the continuum of suicide. And then a couple of weeks ago, I was reminded that maybe possibly um exuberant happiness may be an indicator. Like, you possibly are happy in a way that seems a little bit odd. And of course, self-destructive acts, self-harm does not necessarily mean that someone wants to die. It just means that they're really struggling with something, and that is their coping mechanism. And with chronic truancy, elopement, or running away, well, my question is, what are you running from and what are you running to? So these types of things I consider in my practice. And then also, as I'm talking with parents, when it comes to how do you support your child, your youth, or adolescent who may be on the continuum. And of course, situations, being expelled from school, family problems or alienation, loss of a major relationship, feeling embarrassed or humiliated in front of peers, bullying, and then of course, we know adverse childhood experiences. There's some correlation between ACE scores and possibly the continuum of suicide, and then of course, recent disappointment or rejection. I see that we have 2 raised hands, so I am going to look at those questions. So Nathaniel says, I know a few years ago, there was some Tide Pod challenge. Yes, I'm familiar with that. Now it would be technically suicide if the person died. If they didn't, would be considered an attempt to suicide, or not. Just curious if that was included in the stats that were just shown. No, it was not included. there are multiple ways individuals, children, youth, and adolescents may attempt Nathaniel. So it wasn't broken down. I do know the most common means to answer your question is firearm. And misuse of medication is the secondary, and then possibly strangulation. Those were the stats in terms of means for which individuals may attempt. So when it comes to situations, I think it's important for us to recognize that this is about lived experience. As children, youth, and adolescents, as they are experiencing or navigating their social environment, life happens. And so with life, situations occur, and it equates to a lived experience. And so lived experiences, there's a lot of variability between that, but it's also something to think about in terms of the impact of these lived experiences, right? So I don't want to say bullying in and of itself is the cause or a correlation to suicidality, but the impact, right? The impact on the child, the impact on the youth, the impact on the adolescents. Like, how are they responding to these family problems? How are they responding to recent disappointment or rejection? How are they coping? So it is the impact that we as helping professionals and those who care need to consider. So for us, as those who want to contribute to the ongoing conversation about suicide, especially when we need to work with youth, children, and adolescents, our words matter. We are all very influential. We happen to each other, and we can have an impact. And how we show up in the conversation really, really does matter. And so therefore, the Center of Addiction and Mental Health makes recommendation about person first or identity first language. Very fundamentally, we need to approach the conversation with care and compassion. So keep in mind, everyone's lived experience is going to be different. So that doesn't necessarily mean we'll always understand or even have experience with what they're talking about. But if we can care about what they're saying, demonstrating that in our conversation will make a huge, huge, huge impact. We need to practice consciousness in our choice of words and language. So again, what is that old saying? Sticks and stones may break my bones. Well, wait a minute, they do hurt. So that's where I stand on that. So we need to practice consciousness. Like, how we show up in our conversation is very, 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 very vital, in that we need to avoid reinforcing stereotypes, prejudice, or even discrimination. And then also, are we perpetuating stigma without really knowing it? So that's where that consciousness comes in. And again, imagine yourself in that dialogue. How do you show up in your conversation? That is something that I think about as a practitioner. How am I conveying meaning so that the other person receiving my care is being seen? And so also we utilize terms such as validation and affirmation. No, I'm not validating death, but I'm validating the lived experience. I am affirming that their feelings are valid based upon the situation that they may be within or dealing with. So this is what we can do as helping providers, as people who care. And also, I want to shout out my parents out in the community. Loving a child, being a parent, or the act of parenting is challenging in and of itself. And so I cannot even imagine, oh my gosh, for my child to come to me and say that they want to die by suicide. Oh my goodness, I think I would probably fall out. So shout out to my parents. You matter in this conversation as well. And I hope that you are able to walk away with one thing in addition to those who will be there to support you in the process. So trauma-informed care principles. Why does this matter? Trauma, 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 trauma. Quite fundamentally, we have all had some experience with trauma. But again, it's the impact, right? It's the impact. So when we talk about these principles, it is something that we do, not just talk about. So safety. So a couple of weeks ago, one of my therapists and I were having conversation, our supervision, and she reminded me of something that is so important. And that is, safety is defined by the person So what that means is that it can be co-constructed. Allow the person, the child, the youth, or the adolescent to define what safety means to them, because that can then equate a sense of trustworthiness, right? We, as helping providers and parents, we need to demonstrate that we can be trusted. And it can be something as simple as, okay, Sonya, you said you're going to be there at 10:30, be there at 10:30. If you need to reschedule, then reschedule in a timely manner. It can be something as meaningful as that. And of course, choice. We all have the power and the ability to make choices. Let's not take that away from our young people. They deserve opportunity to make their own choices. And the way that we do that is through collaboration and empowerment. Give them accurate information. Accurate. And I say accurate because we live in a society where disinformation, misinformation is prevalent. And in my mind, I think people just lie. So as a social worker, I am committed to providing accurate information so that young people can make a decision about their care, about how they want it to look, and even with their parents for our younger kids, including them into the conversation, no matter how challenging it may be. I have some thoughts on that too. But this is something that we do. It's not just something we should just talk about. It needs to show up in our behavior, our practice behaviors, that is, and our communication. So, questions to inspire hope. Talking about suicide in general can be very challenging. It can elicit some very strong physiological feelings, such as nervousness. Maybe your pits may sweat. Maybe you might sweat on your forehead. Your hands are sweaty. Maybe you feel fear. Maybe you feel uncertainty. Maybe you feel paralyzed by, oh my gosh, what do I say next? Maybe you are okay with having the conversation, right? And so in my research and also in my practice, we can address the topic of suicide without actually bringing up the word. So I have here a list of questions that may be beneficial. So, questions to inspire hope. What keeps you going every day? Who's important to you in your life? Who do you talk to about your struggles? And you can leave off being suicidal. What are you looking forward to in your life? What has helped you to cope with very tough times in the past? So these types of questions are purposeful and intentional to assess where the person may be currently and where they can be. And so what I mean by that is, quite frankly, especially with children, youth, and adolescents, what are you looking forward to in life? Gives me some insight into, is there a future? Are we thinking about the future? And that correlates to behavioral or communicative indicators that they may not have something to look forward to. And so we kind of have to slow down and pay attention to their responses, because again, it is about safety. Why don't they have something to look forward to? And I know, practicing in Wyandotte County and with my therapist, I oftentimes am concerned, do they have something to look forward to? And if not, why? And of course, who's important to in your life? That assesses peer relationships, family dynamics, social interaction. Are you involved in things that can help promote you? What's happening? It gives me a landscape to kind of assess what's happening without actually saying the word suicide. And I think these types of questions can be useful and can give you insight into the overall well-being of the person that is the nexus of your care. And of course, these types of questions too, to be very mindful of the age of the client. We want to draw them close to us, so we have to meet them where they are, but don't leave them there. So let's talk with them, not at them. And that means we have to be sensitive to their intellectual and cognitive ability. We want them to be a part of the conversation and not draw them away because they don't understand why we're asking these questions, or, just they don't know how to respond. And in my practice, I've had experiences where I've asked questions and they don't know how to respond. So that's on me. That's not on them. So maybe these can be useful in your practice. And these types of questions also, too, guys, can be taken outside of your work. It can be utilized within your family, within your social support system. It can be utilized anywhere if you have someone that you are concerned about who may be on that continuum of suicidality. So let's talk about some tips. How do we go about doing this? Well, first of all, take a deep breath and just notice how you're feeling, okay? Because you matter too, just as much as the person that you're talking with. And you yourself have to be regulated, right? You have to know where you are and how you're feeling that day to engage in a meaningful conversation. And so what you can do is, after you have regulated yourself, is be persistent in the face of resistance. I know sometimes, like I said, having this conversation about suicidality can be sensitive, and I want to honor that, but be persistent. Don't give up on them when they are kind of reluctant to disclose where they are and where they're not. Talk with the person alone in a private setting. I think we're so busy. Our agencies are busy, our homes are busy. Gosh, we're on the phone, we're answering email. Sometimes we just need to be alone in a private setting where we can give someone our undivided attention. And that's a type of affirmation. And that is also a type of validation in your presence, letting them know that that person matters and that you're ready to attend to them in a very, very specific way. And of course, allow the person to talk freely. And again, person is interchangeable with child, youth, and adolescents. Sometimes we minimize what children, youth, and adolescents have to say. So allow them to talk freely. And sometimes what you hear, you may not understand, or you may not have any experience with, but allow them the space. That relates to that safety, right? And that trustworthiness that I was talking about in trauma-informed principles and practice. That safety, the trustworthiness. That's how you can demonstrate trustworthiness, by allowing that young person to just talk, even, and let them utilize the language that they utilize. So if they use a foul word, oh my gosh, don't flip out. Let them express themselves in the way that they think is appropriate, as long as it's not towards someone, but it's about a situation. And of course, give yourself plenty of time. Don't rush. Again, we live in a very busy society. I think our work keeps us busy. I think there's this low hum, as my therapist has said before, this low hum of urgency. And no one's saying to rush, 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 but there's still this, gosh, just this, you can almost feel it sometimes, but give yourself plenty of time. Put your cell phone down. I think being connected can be both a useful tool, but it also can be a distraction. Give yourself plenty of time, put the cell phone down, and if you hear something's not lining up, do not wait, ask the question, okay? You can ask quite simply, what keeps you going every day? You can simply ask, what has helped you cope during very, very difficult times? And then wait for their response, allow them to process. And in this specific setting too, in the conversation that is, silence can be a very useful tool. Giving yourself time to think and to be present, and to give the person on the other end of that conversation time to think and to be present as well. Because sometimes when someone is on that continuum, child, youth, or adolescence, whatever is going on is so big. It is so big. And then you add the feelings on top of it, and it can be very complicated and very hard to give voice to, right? Heck, most adults struggle with that. Heck, I struggle with that, especially if I'm feeling inundated with a lot of priority. Sometimes it's really hard for me to give language to what I'm thinking and what I'm feeling. So imagine a child, youth, and adolescents having that same experience, but their language isn't as robust as mine. So give them time, give them the space, give them the opportunity, and quite frankly, to be messy, right? To just be messy. Because if it's going to save a life, then okay, I'll take it. I'll do it. I'll take it. So what is resilience? So I think it was Monday, I was teaching QPR, question, persuade, and refer. And there was a attendee who brought something to my attention that I really think is important to mention, and that is resilience. What is it? I mean, we talk about it. I think we know about it, but what does that look like when we're trying to support someone who may be on the continuum of suicidality? And this is where I want to hone in on my parents. Shout out to all of those parents out there or individuals who are parenting. It is tough. And so going back through my research, I was reminded that resilience is a process. It is not something that just miraculously happened, as some probably would think. Do you have it or do you not have it? It's not one of those kinds of things, but it's a process and an outcome of successfully adapting to a difficult or challenging life experience. Again, that lived experience, especially through mental, emotional, and behavioral flexibility and adjustment to external and internal demands. I think this is a wonderful definition of what resilience is and what it can be, and it's individualistic. And here's the thing, when I read this, I can't be resilient alone. As much as I like to think that I'm smart and capable, but let me tell you, I cannot be resilient alone. And I'm almost positive our children, youth, and adolescents cannot either. So again, it goes back to that trauma-informed principles and that collaboration. Oh my gosh, I cannot do what I do without the people that I have around me. So I imagine children, youth, and adolescents, they need that same support, right? So several factors can contribute to how well people adapt to adversities, including the ways in which individuals view. So one thing about resilience is that as helping providers, as parents, we can demonstrate a growth mindset, right? We can reflect that, first of all, suicide ideation is quite normal. It happens, right? I have had ideation in my lifetime based upon stressors in my life. And so growth mindset, meaning that things can change if you want them to. You know, you can't allow your mind to be flexible. Because again, sometimes it is not suicide in and of itself. It is the issue. Whatever is bothering that person, it is so big. It is so big. They can't see their way through it, right? They can't see their way around it, above it, or under it. So how can we incorporate a growth mindset? And that could be simply put that cell phone down and listen and say, you know what? This will pass. Can I help you with that? That's that empowerment, asking permission, right? And one of the things I have learned in my practice is I am a guest in my client's life. I am not by any means an occupier. I am a guest, and I feel privileged when a child, youth, or adolescent and their parents and their caregivers allow me to come in and say, hey, what's going on? Allow me to understand and to hear so that I can introduce the possibility of resilience through a growth mindset. And of course, engage with the world. How do we reframe our stress? How do we reframe that problem? Because I guarantee you, they are already doing a lot very, very well. They just don't know it because the problem is so big, right? They can't see through it. And then, of course, the availability and quality of social resources. We don't live unto ourselves. I know it may seem like it, but we don't. We need each other to help that collaborative piece, right? And then, of course, specific coping strategies. We cope every day. Did you know that? I mean, I cope every day. Drinking coffee is my coping mechanism. Driving the car without the radio on is a coping mechanism, especially if I want to decompress from the day. Ooh, I am a true crime fan. Listening to my podcast, it helps me to distract from whatever may be on my mind, or just sitting in a quiet space because my day is so busy. Those are coping mechanisms. So how can we help children, youth, and adolescents cope? And my first question is, do you even know what coping is? Do you know what it is? Maybe you're already doing it and you don't know that you're doing it. Maybe you can cope and then add something else to it and for a different situation. And so what it does is infuse that psychoeducation into the ability to adapt. Now, we may not be able to change the situation, but we can help you change how you respond, therefore reframe, excuse me, how you see the situation. And that requires a lot of time, a lot of patience, because working with children, youth, and adolescents can be exhausting. And they are trying to make sense of their environment in so many ways. So we can infuse resilience through two things: in modeling a growth mindset. And what that is how we show up in our conversations, challenging that deficit focus to help them get to that solution focus, and how they reframe what they see, what they experience, right? And so again, it's a process and an outcome, meaning that it's not static, it's very fluid. So when a child, youth, and adolescent discloses to you that they are having thoughts of harming themselves or killing themselves, it is imperative that we help them, coach them, facilitate how to participate in their own personal safety. So the Stanley Brown Safety Plan is a very useful intervention. It's brief. It is readily accessible. You can Google this document and print it out, or you can also look into any app store and download safety plans. And so here at my work, I emphasize that developing safety is a collaborative conversation. I should not be the one dictating what is safe for somebody else. I should not be doing that. But I should be doing is asking meaningful questions to help that person identify how they can be safe, right? And that is, first of all, what are your warning signs? Or how do you know you're having a bad day? Do you feel something in your body? Is it exhaustion? Is it irritability? How do you know? What are those warning signs? So are they paying attention to their own self to know where they are and where they're not? Second, internal coping strategies, things that you can do to take your mind off things. Again, my two things is listening to podcasts and being quiet, being silent. So how can you ask those questions to help that child, that youth, and adolescent identify how they can take their mind off what is troubling them? And of course, people in social settings. It is imperative that young people have support. Now, support isn't always support. Sometimes some support can be not helpful. We want to ensure that young people are interacting with people who are going to be supportive in a healthy way. And we want their name and their contact, right? And again, it's not only about people, it might be a place. So for example, let's just say they want to go to the zoo, or they want to take a walk, or they want to walk their dog, or they want to plant something, put their hands in the dirt. Maybe they want to go exercise. So maybe it's the gym, maybe it is going to grandma's house, right? Or maybe I like to hang out with my friend down the street, as long as my mom knows that I'm down there and the person who's the adult in the room in the house, right? It could be that. And of course, who can I ask for help? Asking for help, oh my gosh. Do you guys have a hard time asking for help sometimes? I know I do. It depends on the situation. So imagine the child, the youth, the adolescent struggling for asking for help. Because, because I think it reveals vulnerability. It reveals, I don't know how to do something. It reveals that I can't do this alone. And that means that we can be very vulnerable, right? So let that person identify who they want to talk to during a crisis. I shouldn't be dictating that conversation. It is them identifying them, because the goal is that they are going to utilize this plan, not me, right? And then also reasons for living. What will help you to live? Is it family? Is it, I don't know, your pet? Is it your friend? who is going to help you to find that reason to keep you living, right? Because if we can help you engage in your own personal safety, we have saved a life, guys. We have saved a life. And then, of course, number 6, making the environment safer. So when we were having the conversation about suicidality and they disclose that they have an intent, that there's a plan, then we need to ask very specifically, how would you accomplish that? Where would you accomplish it? What would you do? Right? And that's, you're assessing means. What would be your means? So for example, let's just say medication, misuse of medication. Well, if that is their means, then we need to take the necessary steps to restrict that availability. It could be a lockbox for the medication. It could be the adult distributing the medication and watching the youth take the medication. It could be also putting the medication in a place where they cannot easily access it to be misutilized. Or it could be sharp items, removing, and this sometimes can be a challenge for homes, and that is if blades is a means to hurt themselves, not removing knives, any sharp instruments. And I've been told in my practice some very clever ways that blades can be accessed. So for example, just yesterday, one of my therapists mentioned that the pencil sharpener, the small pencil sharpener where you stick it in and you twist it, there's a blade in there. He dislodged that and utilized that to hurt himself. So it's thinking through those types of pieces. And then this is why including other people in the conversation is so vital, because they can help you restrict these types of means, if that makes any sense. So safety planning is about the person, it's about the child, youth, or adolescent specifically, and they need a copy of their own plan. They can take a picture of it with their phone, they can download the app, they can put it in their back pocket, however they want to keep their plan readily available to them so that they can utilize it when they're having a hard time. Okay, so we have come to the end of our time together. I hope I didn't rush too much through that, but I wanted to give some time for questions, concerns, or comments, opportunity to process. So here are some resources. 988 is the Suicide and Crisis Lifeline. I have put a link in here to how to utilize that, because once you dial 988, it will take you through some prompts. And of course, if you want to learn more about suicide and how you can be a contributor to it, and the one way that we can do that is by learning about it, what's true and what's not true about suicide, is the Kansas Suicide Prevention Headquarters. And of course, if you have a child, youth, and adolescents who need that support, here are some resources. There's PACES, which stands for Parent, Adolescent, Child Empowerment Services, Family Conservatory, the Child and Family Guidance Center, Vibrant Health. And one thing I want to add too is sometimes stress can be psychosomatic. Are the kids seeing their doctors regularly? Are they going to the dentist? Because sometimes we need to rule out medical dispositions to understand what's really going on. And then, of course, Cambridge Children's Mental Health, they are more than just an acute hospital. They provide an array of services, not unlike Child and Family Guidance Center and PACES. And of course, KU Child and Family Services located in Lawrence. Here are my source materials where I frequently go to. I want to shout out Mika Gentry. She is one of my therapists on my team. She helped me to think through safety in a different way. Brittany Saunders, who is also one of my collaborators here, she reminded me that parents need to be shouted out. They need to be recognized. Those who also parent. Thank you so much for that. And of course, the Zero Suicide Committee here at PACES. Again, I can't do any of this without them. I learned through from these people, and hopefully they learn from me. And I hope that you have been able to gain one thing from this conversation regarding suicide. So if you have any questions, concerns, or comments, I would like to take the opportunity to open up the floor to begin that. So let's talk about it.
Sonya, as we're waiting for questions, I just want to say thank you. I know there was a lot to chew on, but a lot of really wonderful information. I know for me, the one thing that stood out was those questions to inspire hope.
Yes.
Having something practical that I can go into a conversation with, just so helpful.
Yeah.
I know we've had a few questions. I know the chat is moving quickly, but let's see. Jennifer asked, what if they're having trouble finding a reason to live?
Hmm. Well, I would definitely ask, I would encourage that you continue to process that. Because that means if they cannot find a reason to live, we may need to add another layer of support in that conversation. Are we missing something? Are we not aware of something regarding the person, the child, youth, or adolescent who may be disclosing that? Because I'm almost positive there may be a reason to live. They just may not be aware of it. And also, too, what in my experience, um, when someone is overwhelmed, their ability to think is restricted or constrained. And so they can't see past it. So asking those types of questions, I think, or like, what's your reason to live, may be hard for them to respond to because all they know and see is the issue that may be bothering them for a long period of time, that is. So ask that next question. And if they don't give you a reason to live, then how can we get them engaged in their own personal safety?
And then Sonia, Mark asks, at this time, 11 US states have legalized physician-assisted suicide. There are strict guidelines and requirements. This is not about pain management, which can be improved, and or rash decisions. Thus, suicide is a complex issue which occurs in a context, state/community. What are your thoughts?
Um, I was introduced to this concept, gosh, when I was in graduate school, and I didn't really know what my thoughts were on it. Um, it is an ethical dilemma for me. So I don't know if I have a direct answer to that question. Is it the right for the individual to die? Is it their right? That is something that I'm chewing on. And I think it will be contextual in that, like, if it's a terminal illness or if it's advanced age coming to the end of their life and they're in pain, it is a complicated thing to think about. So I don't know if I have a direct answer for that, but I am willing to admit that it is definitely an ethical dilemma for me as a social worker, because I can't, is it their right? And self-determination, I do endorse as a social worker, meaning that it is their social responsibility to self-determine what's in their best interest. But does that include death? Very good question. Thank you for presenting that. I have no idea how to answer that. It's complicated for me.
Very complex question. Pamela asked, when would you contact 911 for possible hospitalization?
When you know that you cannot help a person ensure personal safety. So if you are unsure that that person is unwilling to engage in the process of keeping themselves safe, then yes, let's get other helping professionals involved in the conversation. And when you do that, please explain why you're doing that. It is imperative that we slow down and say why we're adding this other person to the conversation. So especially 911, because that can be very alarming and it can create feeling of fear and hope, powerlessness. And so if you find you are in a situation or in an interaction with a child, youth, or adolescent and their parent, and you cannot ensure safety, meaning that you don't trust that they will keep themselves safe based upon the steps that you've already taken, then by all means, let's get 911 involved and let them know why you're calling and stay with them, please, because it can be scary. Hospitalization can be very intrusive because essentially what you're saying is I need to restrict your ability to move about your social environment because of that. And sometimes, Pamela, that is necessary, okay? It is necessary, but I think it's the education as to why we're taking those necessary steps.
Let's see. And then Erica asked if in a primary care clinic setting, if a teen discloses suicidal ideation with no plan or intent, are you required to report that to their parents?
Yes. Yes. Yes, because it's about safety. And again, we can't, so trauma-informed principles, collaboration, parents or those who parent or in the act of parenting, we need their help in ensuring that safety. So we need to let them know that, hey, they're having these thoughts. This is what you can pay attention to. You can talk with them this way or versus that way. You can need to add them to the conversation to wrap around that teen because it's all about safety. And we can't care for parents, for children, youth, and adolescents alone. We need their parents' help or their caregivers' help. And I know that can be scary. I know they can be very scary, but we have a responsibility to initiate that conversation with those parents and the caregivers. So yes, Erica, excuse me. Yes, we do. We need to let them know.
Absolutely. I know we've had a couple of questions about PowerPoint slides. Sonia, I don't know if you're able to get those to me, and I will then try to figure out how to get that out to everyone here.
I will do that today. Thank you.
Perfect. And we will also have this webinar has been recorded, and so we'll get that posted on mentalhealthkc.org as well. I'm going to go ahead and drop in the chat a certificate of attendance link and a password, and so you are able to use that to download a certificate of attendance for today's session. Let's see, we have a question from Leslie. Questions to Inspire was really helpful to me, coming from a mom that has an 18-year-old daughter that has attempted suicide multiple times. She's been in counseling since she was 12. Let's see. How do we help someone who has endured a lifetime of trauma and seems to continually be faced with more with no end in sight? How can we help them find hope and increase empowerment when it seems out of reach?
That's a big question, Cherie. Very good question, but a big question. So first, I think I would recommend psychoeducation on what trauma is, how they recognize it in their own life, right? Arm them with good information so that they can make informed decisions about how they want to, what next steps they want to take, especially if they've had a lifetime of trauma. I worked with a woman when I was a medical social worker at KU, to your point, Cherie. And she endured a lot of trauma. Gosh, a lot of trauma. And she unfortunately experienced chronic suicidality when her stress level was pretty high. And the work that I did with her across several months was just teaching her how to cope. And I know that may seem like that's nothing, but how can we cope in this moment? Again, sometimes a traumatic event can be so big. How can we make it smaller? And how can I help you to respond to that trauma or that trauma response? Because sometimes it's a trauma response. How can I help you cope when that trauma response occurs? And again, it's just teaching them how to care for themselves, because unfortunately, individuals who've had a lifetime of trauma, they may not know how to take care of themselves when they are quote unquote triggered. I am a firm believer in hope and resiliency. There is light at the end of the tunnel, but are we looking for it? Are we looking for it? And how does that show up in my conversation? How can I help you today? What are you willing to do for yourself in the next 5 minutes to help you manage what may be so difficult for you? And again, we're talking about the complexity of lived experience. It's not a one size fit all. We might need a toolbox, Cherie, of strategies to help that individual see that there can be something seen at the end of the tunnel, if that makes any sense. And it's giving them the option, right? And then here's something else. I struggle with this as a social worker, and that is, if someone wants to die by suicide, they will. Now, am I promoting that? Nope. I am not. So please hear me when I say that. But it's not my decision. It's not mine. And I want to interrupt that, disrupt that, as we call them disruptors. I want to interrupt that. But if they are going to do that, they will. They will. And that's painful to accept because that's what's happened in my family. In 2012, I had a family member that died by suicide in a very violent way. And it was her, we were all stunned, all stunned. And um, it felt like we couldn't do anything about it. Right. And so she had a lifetime of trauma, Shuri, a lifetime of trauma. And we felt paralyzed. This is why I like having these conversations.
I want to get to Gina, who has their hand raised. All right, Gina, you should be able to come off mute if you'd like to. Give Gina a minute. I know, Sonia, someone had asked, I believe it was Georgie, about how they could contact you if they want you to present to another community group.
Oh, I would love that. Thank you so much. So do you have, you know what? I'll put my information in the chat and then we'll go from there, okay?
All right, and then let's see. Joanne has, I think, a question. Joanne, you should be able to come off mute.
When you have somebody that has had multiple attempts
Mm-hmm.
and you're trying to build in resources, but the family is kind of against that, what do you do?
I would want to talk with the family about what their hesitation is. I really would. I would want to know what's going on. Talk to me about that. Are
Okay.
you scared? Are you anxious? What is it? Let's talk about it. And so one of the things that I've learned in my practice about working with families who may not be, I don't want to label here, who may present in a way that they struggle, we need to address that. As a practitioner, it's my responsibility to address what's uncomfortable so that we can get to the solution. And I know people in general, families, oftentimes are extraordinarily scared. And I just want to validate that. And sometimes fear of not knowing what to do can be very paralyzing to where it may appear to be resistance or non-compliance, but there's some underlying feeling in that. And I think that's, as a therapist, my responsibility is to call attention to that in a respectful way. It appears to me that you're struggling with what I'm saying. Let's talk about that. What are your thoughts? What are your feelings? Right? And I think that has helped me help them get to the solution.
Thank you.
We've got about 3 minutes left. Any other questions? I don't believe I've missed any yet. If I did, please repost it in the chat and we'll get to it. Just a lot of thank yous rolling in, Sonia. I know I saw one, greatest presentation on suicide prevention. So,
Oh, wow. Thank you. Gosh, you're going to make me cry. That's great. Thank you so much for that.
any other questions? I'm going to repost the certificate of attendance information in here one more time, just in case anyone didn't catch it the first time.
Does Gina have her hand raised? Did we
Yeah,
get
Jen, I don't know if you're able to come off mute. I think you should be able to if you're still with us.
Well, Gina, if you hear me, you have my email address in the chat. Feel free to send me your question if you have one or a comment, concern.
Let's see, Mark, how can we have a presentation on a growing demographic of elderly who at some point outnumber children. Would like to talk with someone regarding this issue, regard to suicide. Mark, that's definitely something that I can take back to the Metro Council and see if that would be a topic that we could address, whether at the Mental Health KC conference in May or in a future webinar. All right. If we don't have any more questions, I want to again thank Sonya and remind all of you that we would love to have you join us for our next webinar. That's going to be on Thursday, October 10th. So you should now be getting our emails, and so we'll be sending out that webinar information soon. But in the meantime, have a wonderful day and a wonderful weekend.
Thank you, everyone. Have a great day.
Sonia, I put your email in the chat one more time because someone else was requesting contact information. So I just pasted it in there again.
Perfect. I will send you the PowerPoint slides right now.
Perfect.
I will not forget. Is there anything I can do better in the future when I speak? Sometimes I hear myself and it seems like I'm going so fast, especially for